guess that's recording. I guess we'll find out, right? There's the button. Okay, so what are we going to talk about today? I really want to talk about basic principles of pharmacology. Has anybody had a pharmacology course? Okay, that's great. We're not going to go probably, like full on into pharmacology because we kind of have to talk about other things. But it's going to be fun stuff. Some interesting things. If you've not had a pharmacology class or a biology class, don't worry about it. We're going to get you caught up. We're going to get you where you need to be. That's the point of today, right? Try to make sure we're all on the same page. All right, so we do want to talk about drug action. That's really what pharmacology is, right? When you take a drug, it does stuff, right? We all know this. How many of you are drug users? There we go, right? Like one person raised their hand. Nobody else is going to, maybe admit to that. That's fine. If you take Advil, I mean, that's a drug, right? I mean, so you're a drug user. If you've ever been to Starbucks, you're a drug user because, there's caffeine, right? Lots of folks use nicotine, alcohol. Some of you are old enough for that. Some of you may not be. Anybody? You don't have to tell me. I'm going to assume most of you are almost 21 or over, right? That seems like a reasonable assumption. So those are all drugs that you can obtain legally, at least in this state. There are other drugs you can obtain legally in other states, and maybe eventually in this state, for reasons other than, like pain management. So lots of folks have been using drugs, and we've been using drugs for a long time, right? As a species, before we were a species, we were using drugs, right? They've found like ancient, human species with sort of, different residues in their mouths, and that's kind of interesting. They recently found a Neanderthal skull that had like some willow bark. Yeah, I know, right? That's pretty awesome. The guy had a toothache, he had an abscess, and the willow bark, there's like an ingredient there that you can pull out and you can, make pain relievers and stuff. So it's kind of an interesting thing. So he's like chewing on this wad of, pain reliever. It's pretty cool, right? I mean, if you think about it, it's like, we always think about those folks as like, those, ancient human species, they weren't worth anything. And what do they know? Well, they know a lot. I mean, they were like chewing on this bark that was giving them some pain relief. Caleb, you had something?
Isn't aspirin derived from?
It is. It's aspirin.
Aspartic acid or something?
Yeah, it comes out of this bark. So there you go, right? Stop buying aspirin, just start chewing tree bark. Right?
Especially around here in Huntington.
Should be a piece off.
Who knows what kind of high you'll get.
Definitely will help. We're going to talk a little bit about drug action and something called pharmacokinetics. That's a very fancy word for like how drugs move, right? And how they move through your body and what they do. Obviously, we've kind of identified a couple reasons folks take drugs. There are therapeutic reasons, right? You're trying to get some relief, and there are recreational reasons as well, right? And this course we're going to discuss both of those, right? So we're going to talk about that. It's going to be interesting. For a drug to work, pretty simply, you have to have a receptor that it fits, right? You take a drug, it's got to interact with part of your body somewhere. Now that sounds really vague right now. We're going to get past that, so it's going to be less vague, right? I love these, you ever talk to somebody and they're like, oh yeah, I take this drug, it just does something to my body and I feel better. Yeah, and that is exactly true. That is 100% accurate. It gives me no information about really what's going on, though, right? It's like, well, there's just something in that drug that works. It's like, absolutely. We're not going to ask you to, draw the chemical structure of drugs. That's probably for something in one of the other buildings here, not in this building. But we will ask you to think about shapes in those interactions, right? And that's going to be really important when we talk about exogenous versus endogenous substances. And if you don't know what that means, that's fine. We'll figure it out later. We might talk a little bit about chronic drug use. Anytime you take a substance for an extended period of time, it's going to have some effects on your body, right? Some of those can be short-term, medium-term, some of them can be long-term. We'll think about that just a little bit. We will talk about some pharmacogenetics, maybe personalized medicine. Actually, guys, you guys are living in a great time for drugs, right? You're also kind of living in a not so great time for drugs. And for any of you who have tried synthetic, I hate to call it synthetic marijuana because that's not exactly what it is. Tried some synthetic THC, you might have had a psychotic breakdown, you know what I mean. marijuana contains other substances. If it was
Yes.
synthetic marijuana, and that's the reason people on like K2,
Oh, is that why they freak out? 'Cause
they freak out because they don't have the
it's
CBD.
other- Gotcha.
Yeah, and they don't have that
Right.
sort of mitigating their,
There for a second, I was really confused.
yeah,
Like, what?
no, that's why.
Okay.
So with all cases, I typically say natural's better, so go with natural, right? If you, Caleb,
What about the Tura?
huh?
What about the Tura? That's natural.
It's a general rule, there's gonna be exceptions.
It's not better though.
Well, there are exceptions to every rule, Caleb.
All right.
And so we're gonna have those, right? Most of the time, the natural substance is going to be less effective, right, than the artificial substance, and that's because the artificial substance was designed with the intention of being more powerful than the natural substance, right? And so often those side effects and those therapeutic or recreational effects will be more effective, and they may not. Well, here's sort of a broad thing I think you should know, right? There are like very few people doing like drug research on people, right? And we in the past did a lot of, it's like a period of time where they were like doing a lot of drug research, particularly like LSD, right? And I was like, okay, let's give people LSD, see what happens. And then they decided, well, that's probably a bad idea. And so that kind of stopped, and then it's resurfacing now. But what that means is we don't have a lot of information about how some of these drugs actually work, right? And because we don't have that information, then often we don't know. When we go in there and we start tinkering around with things and we try to make it more powerful or change the shape of that drug molecule just a little bit, we're not really certain what those side effects are going to be, right? How does that change the action of that particular drug and how that's going to affect your body? And then this happens a lot. Like we just figured out that maybe ketamine has some effect on opioid receptors, which is kind of impressive, right? Didn't really know that. People have been using ketamine for a long time, and that's something that just came out in the last few months, that they figured out like, hey, that might be why it works for some of the, because they'll give ketamine to folks who have depression, which is sort of interesting, but we've always thought it's been working on a different receptor. But those are things that if you don't understand what I just said, in 3 weeks, hopefully you will. So we're going to study drugs and its effect on living organisms. That's going to be awesome. Most of the drugs prior to the 20th century were natural, right? Pick up a plant, chew on it, see what happens. Wow, that felt pretty good. So we're just going to keep doing it, right? And there are a lot of folks who still use herbal medicines. There's a lot of crap out there too, right? That's like, oh man, chew on this and you'll, cure that broken foot you have. It's like, well, I don't know about that. But that's not to say that plant-derived substances, that's the vast majority of the drugs we have originally started as plant-derived substances, and then a biochemist or two put their heads together and said, hey, man, this is pretty awesome. What if we just bend that hydrogen a little bit this way and see what happens? And then the next thing you know, it's wow, that's even better than the other drug we had, and so we'll go with that. So there you go. Neuropharmacology, psychopharmacology, they're just kind of fancy words, thinking about effects of things on the nervous system and your thinking and behavior. Not a big deal. Kind of skip that. Drug action, if we talk about this, we're thinking about things at the molecular level, right? And that's where it really, even if you're not a molecular biologist, I'm going to assume most of you aren't, are exceptions to every rule. You want to think about that molecular interaction. That's what's important, right? When you take a drug, it's a molecule. That molecule has some particular shape. That shape is going to interact. For our purposes, we're going to think about its interactions with your brain cells, right? And the receptors on your brain cells and how that interaction happens and what that changes to the function of your brain cells, right? In particular places. And so that's really what we want to think about. Those changes are what we call drug effects. Not a big deal. Where the drug does its business and where you feel its effects may be two different places, right? They may not be the same place. Could be. It just kind of depends on that particular drug. Not a big deal. When we're thinking about drugs, we typically think about something called therapeutic effects this is what we were trying to get out of the drug, right? I like to use therapeutic and recreational effects, right? Because I mean, if somebody's taking LSD, I guess there are therapeutic effects to that. But there are a lot of folks, they do like microdosing LSD. We'll talk about it. Just hang in, it'll be interesting. Just don't go around. Some people don't listen to everything I say, Brandon. And there's a group of people running around on campus who thinks that I told them to take LSD.
You did.
And what I told them was, if you're going to take drugs, take LSD. That's a completely different statement.
No, it's not.
It is.
It's the same thing. You told
It's
us
not.
to do acid.
It's safer than a lot of other things that you could do. Yeah, it's very safe.
He
actually.
did tell us.
So, I'm not saying, I'm not endorsing, not until they legalize LSD and I can buy some stock in an LSD company. Would I be endorsing you to do LSD? But the point was it was safe. But so we're going to think about therapeutic or and recreational effects, and that's what you're trying to have happen, right? So if you take morphine, for example, morphine's a great and effective drug. If anybody's had a major surgery, you've had a broken bone, you've probably taken morphine or some similar substance to morphine, right? There are a ton of sort of similar substances there. Phenomenal at dealing with pain. Also phenomenal at keeping you from breathing, right? That's what we call a side effect, okay? Something that's unintentional, all the other effects. Some side effects can be fatal, some side effects can be irritating, some can just be weird and quirky, right? They don't necessarily have to be detrimental to your health to be a side effect, okay? Often we think about side effects, the ones that are important to us are the ones that can kill you, right? So if you take a lot of morphine to deal with your pain, it depresses your breathing, so you could stop breathing. That's an important side effect, right? Another important side effect of opioids is constipation. So some of you might think that's important to think about.
I wish Elvis had taken this class.
Huh?
Elvis should have taken this class.
He should have, right? He would have known. He would have known. Do LSD instead.
See?
See, I could have saved him.
You could have saved Elvis. What?
Too bad I wasn't around. You know, I actually have the same birthday as Elvis.
Do you?
Yeah, Elvis, David Bowie, Carl Rogers, and Stephen Hawking, all of us on the same day. All of us geniuses in our own fields.
Right. Can your ego fit through that door?
Well, we'll see. I seem to get in okay. So there's specific drug effects, non-specific drug effects. Nothing really to worry about here. For specific, we're thinking about what are those physical interactions, those biochemical interactions. Non-specific are things like moods, expectations, perceptions, attitudes, right? Those can definitely, especially when we're thinking about psychoactive substances, your sort of mindset coming in would definitely have an influence on that particular experience. We just happen to be on a great example here with LSD. You know, sort of your mindset coming into using LSD can really affect whether or not that's like a, you know, a good trip, so to speak, or a bad trip, right? So if you're going to do drugs and you've decided it's LSD, always go into that positively, right? Always come in with a positive attitude so you don't have a bad trip.
Does
Yeah,
the
ma'am.
non-specific drug effects include the like physiological unique characteristics of an individual?
Yeah. Can be. Placebo. How many of you have experienced the placebo effect? Yeah. It was when your mom kissed your knee when you fell off your bicycle. That's a placebo effect, right? Mom's like, oh, this is going to work, and you start feeling better all of a sudden, right? So, oh, whatever. Placebo effects are actually, they're non-specific. They're real. They definitely are. I mean, and there are a number of studies that have looked at brain scans of folks while they're experiencing a placebo effect, and there are specific brain regions that get activated, Seth, while that happens. So it's a very real effect. Placebo effects are one of the reasons that it is so difficult to get an antidepressant to market, right? So you can give folks an antidepressant and they feel better. The problem is often, what are side effects of antidepressants? You're sleepy, sexual dysfunction, maybe increased risk of suicide, weight gain, right? You have a lot of side effects potentially of even the sort of milder antidepressants. But you can also feel better just sitting down talking to a guy, right? So you feel a lot better doing that, and there really aren't a whole lot of side effects there. So when we bring a drug to market, we want to make certain that the benefits outweigh the risks, and those benefits, and there are going to be risks, but that they're not more severe than what's already available or some safer method, right? So we don't want to develop a drug that, wow, this drug works just as well as Advil, but it'll definitely make your arms fall off. Nobody's going to take that drug, right? Just take Advil. It's safer, and your arms stay attached. So, you know, why would you take that other drug? Right? So this makes a lot of sense. But definitely a real physiological effect with placebo, even though there's not that biochemical interaction, right? Because if you're taking just a placebo drug, whatever that is, it's not in any way creating that biochemical reaction, that biochemical interaction at all, but you can still experience some of that, those physiological effects. So that's exciting, right? There was an interesting study a few years ago where they gave folks, it was a placebo study. It's kind of cool if you want to really think about a non-specific effect that's your mindset coming in. So let's say we did it in this class, right? We'll take this half the class and I'll say, hey, I've got this great drug that's going to treat pain, okay? I'm going to give it to you, and then I want you to tell me how good it is at dealing with your pain. Now, that's a very expensive drug, right? It's a very expensive drug, so we're just doing some experiments before we bring it to market because we want to make sure, right, it's just expensive. So you guys, okay, so we give you this, it's a placebo, wasn't a drug in the first place, and you go like, okay, well, it helped my pain, you know, a certain amount, right? Placebo effects are real, we know that. Other half of the class, we go, hey, I got this new drug, and it treats pain, so I'm going to give it to you. But guess what? We got a 50% off deal today. Man, it's on sale, super cheap. It's going to help you out, though. So you guys go, okay, we'll take it, and your pain gets better, and you rate how much that is. What's interesting, the folks who paid full price, or thought they paid full price, for the fake drug, actually thought it was more effective, right? Because they, you know, if you buy something and it's on sale, that means there's something wrong with it, right? Okay, so it's not going to work as well, right? And they think the same thing, you know, it's a placebo effect. So it's kind of an interesting thing. So what I always try to tell myself is, this Advil I'm taking is the most expensive headache medication ever created. And you just take like one, and, you know, even if I have an open head wound, it just disappears.
Because you're breaking foot too, doesn't it?
Yeah, it does. You should have tried that. So, placebo effects are real. They can be very powerful, and they can really cause a lot of problems for folks trying to develop drugs that they want to bring out to the public. But, you know, they keep you from bringing things that are dangerous, right? Let's see. Not a big deal there. And here are just some basic effects of placebos, some things that might experience that, your expectations, social learning, conditioning, whatever, genetic variants. Here's a nice flow chart. We're not going to spend a lot of time on that. There's the nocebo effect. Boy, that sounds like fun, right? This is interesting. So, how many of you have ever taken a drug from your doctor and didn't really bother to read the side effects? Yeah, it happens all the time. People do it. They're like, doc says, "Hey, man, this is the drug you need to take," and what do? You go to the pharmacy, you get it. They give you that big sheet of paper. If you're a nice person, you put it in the recycling bin. If you're not, you throw it away, right? So I'd like you guys to recycle if that's okay. If you read those side effects, guess what happens? Well, you've actually kind of increased the likelihood you're going to experience those side effects, right? Because again, you have that sort of expectation, right? You've set up that negative expectation. You're going to be more likely to experience negative side effects. Now, this is not me telling you don't read the side effects for your medications. I think that's really important to read about your side effects, okay? But maybe just don't dwell on your side effects, right? Don't read the side effect. Well, this is definitely going to happen to me. Guess what? It probably is at that point, right? Which is actually kind of an interesting thing. So there you go, nocebo effects. We've already talked about this control. Double-blind experiments, that's kind of the hallmark and the gold standard for a drug test, right? So if we're going to test the effectiveness of a drug, we're going to find a bunch of people. Half the people we're going to give the drug to, the other half the people we're going to give a placebo. The people who are taking the drug don't know what drug they're taking, but it's also important that the people administering the drug don't know what drug they're giving, right? So you have to have these double-blind experiments where obviously someone has to know what's going on. but the actual folks running the experiment, they don't know who's getting placebo and who doesn't, because you can actually affect the outcomes, right? Based on the way that you talk. Let's think about it. You're giving, here you go, take this drug, see what happens. That's what you're going to do for the placebo. I'm just wasting my time with this guy. I'm giving him a fake drug. It's not going to work, so I'm not going to be enthusiastic. Somebody comes in with this great drug you've developed in your lab. Wow, yeah, this drug right here, this is definitely, you're going to feel so much better. Just positivity all around. We've already talked about placebo and nocebo effects, right? So guess what happens? If you know what drug, if you know you're given a drug or a placebo, you can really influence the outcome. So there you go. What do we want to think about if you ever talk about bioavailability, right? That's basically how much drug's floating around in your blood that could bind to target sites. It's free to bind to target sites, right? It's not bound, it's not doing its business, it's not been broken down, it's not been excreted, it's floating around in your blood, it is available for you to bind, right? That's what we mean by bioavailability, okay? You could take a gallon of a drug. That doesn't mean a gallon of it has become bioavailable, right? Okay? Because it has to get absorbed, it has to get into your bloodstream, has to not be attached to something else, and so forth. And we talk about pharmacokinetics. That's really going to be what's going to contribute to that bioavailability, right? Because it's the movement of these drugs. Now, when we think about pharmacokinetics, there are a few steps, right? Every time you take a drug, no matter how you take the drug or what that drug is, it goes through some variation of these steps, right? You've got to administer the drug. There are tons of ways for you to take drugs. Often the same drug can be administered multiple ways, right? And some drugs can only be administered in particular ways, given the nature of the drug and what happens. So once you administer the drug, it has to be absorbed and you have to distribute that through your body. It's going to bind to sites in your, in our case, we're going to think about the brain, right? But if it's a drug, it can bind in other places as well, liver, heart, kidneys, whatever, that doesn't really matter. Tissue's tissue, really. It's going to be inactivated, right? So drugs don't last forever. Right? How many of you have ever taken one pill and that was just all you ever had to take for the rest of your life? Right? You were like, man, I've got Advil, got a headache today, I'm going to take that one Advil, I'm not going to have a headache for decades. It doesn't work that way, right? Because it breaks down. Okay? It becomes inactivated. There are enzymes that break it down. Time breaks it down, right? Stuff happens. And then we've got to get rid of this stuff. And there are a few routes of excretion, but there's one major route of excretion, right? And that's through That's actually not a bad kidney, is it?
It's a really good one.
I thought that was a fetus.
You're not a biology major, are you? Right. Let me draw another. Now the hard part is like, can I draw another one over here?
I think that one was from someone else.
Yeah, definitely a donor kidney.
This is what happens when you only sleep on one side all the time. Smashes your kidney. So you guys got to rotate. You got to rotate at night. You'll never forget that, right? Now, how many of you are going to go home and like set your alarm for like every hour to rotate? It's like sun tanning, right? You got to like rotate every hour so you don't squash your kidneys. You guys ever think about those things? Like, no, nobody thinks about it.
No, that's why I take your classes.
So I can think about it for you. Yeah. No.
Work smarter, not harder.
And then down here somewhere, it's kind of hard to draw like the bladder in here now, but there you go. There's a bladder. It's not a horrible bladder. I ran out of space.
It got smushed with the other kidney.
Yeah.
Those are
Yeah.
pretty big kidneys for a teeny-tiny bladder.
Yeah. She's right.
Yeah, I mean your kidneys are like, a bar of soap or something, right? They're kind of small. And then they also have, so since I should, like, you've also got this like little elf hat thing on top, right? Because we're going to talk about adrenal glands at some point, right? And so those are kind of important. So anyway, the major route of excretion is going to be through urine. That's exciting, right? So this is always a fun thing, like whatever drugs you've taken, some metabolite of that has come out in the urine. How many? You don't have to answer. Well, I was going to ask how many of you have had a drug test. And I'm going to assume a number of you have, for perfectly legitimate reasons, not because the court said so. And that may be for you too, and I don't mean anything negative about it. You know, you just got to take it and you got to move on. So I'm not, for those of you that don't know me, I don't put a lot of judgment on things. I just kind of say whatever. And I'm not going to think any more or less of you if the court did say, hey, you got to pee in a cup once a week for me. It's your life right now, and you'll get through it one way or the other. But a lot of folks get job opportunities, right, Marissa? And so some jobs will say, hey, you got to do a drug test. One of the ways they'll do a drug test is they'll have you pee in a cup, and then they'll swirl it around, take a sip, see if there's they'll test it for drug metabolites, right? This is also one of the ways they test for other problems, right? So if you're diabetic, if you've got high blood pressure, there will be funky things in your urine, and they can do tests for that, right? The only things that should be in your urine is urea, water, and salt, like sodium, right? Those are really the only three things that should be in your urine. If there's anything else in there, you've got a problem of some sort, right? I mean, I wouldn't say necessarily a problem. There are other wastes that go in there, other, you know, if you've taken some other medications or whatever, there you go. How many of you have ever eaten something or like taken some multivitamins and your urine's a different color later? Yeah, no, yeah, go ahead and admit to it. We know what happens. Right, beets. Do beets do that to anybody?
Asparagus.
Asparagus, yeah.
And if you're getting a UTI and you take those azo cranberry pills, you get highlighter urine.
Yeah.
It's like highlighter orange.
Huh,
Yeah.
that's
It's
interesting.
really alarming.
Yeah,
When you forget
it's-
that you take it.
Or,
You know,
like the first time I took it, I thought I was gonna have to go to the emergency room, and my
like
mom was like,
very
"Jeanette,
alarming."
calm down."
Well, there you go. And then there are like 3 people or 4 in this class who are going like, UTI, what's that? You probably don't have to worry about those. So, if you can grow a beard, you're probably not going to get one. That's, you guys can, if my slide was longer, I could show you why. But I've run out of space, so I can't draw the rest of the urinary tract for you there. For some folks, it's going to be like this, and for some folks, it's going to be like that. And that's going to be why. Those of you with the shorter tracts, you're more likely to get infections. That's a true story. Not that it can't happen to you, but so it's like. But you got to deal with other things too, right? Got a few decades before you got to worry about the prostate, but it'll jump up and grab you one day. I mean, it's going to happen, right? I mean, it's.
Sorry, I just like pictured a little prostate.
It is kind of what they do. I mean, they do just kind of grab you and
Like where I know all the anatomy.
It's
Just
up to this is a nice chart, I guess, if you want to think about it like this. It's, you know, you got to take the drug first, talk about different routes of administration. However you've decided to take that drug, it's going to get into your body, and it's going to be distributed primarily through your vascular system, right? I mean, that's like that guy goes everywhere. It's going to, you know, bind to your target sites. You might store some of it out in bone and fat. That happens. Sometimes you can store things out there, like if you take enough of a drug, right, you can store some, and then it'll kind of like come back out of there later over time, right? You can get like steady state and stuff. We'll talk about that later. You do want to inactivate this, and then you have these metabolites. We'll talk about some interesting situations where the metabolites are actually the drug that you wanted in the first place, but you couldn't take that because it would have been broken down by your stomach acid, for example, or something else, and then you're going to get that out through your excretion process, and you know, have fun with that. So we'll talk about those things as it goes. So what are things that affect drugs, right? How rapidly does it get to its target? That's important, right? The faster it gets to its target, the more profound the effect's going to be. If you have used drugs in the past, particularly drugs of the same class, right? Because you can develop tolerance. I think we all have some idea of what tolerance is. Hopefully, when you leave this class, maybe not today, but you know, in the next few weeks, you'll have a really good idea of what it means to develop tolerance, right? Most people think, well, over time, your body just gets used to taking a drug and you have to take more. And while, again, that is 100% accurate, it is about 3% detailed. And it doesn't really tell you anything about what's going on at that biochemical level. All right, so what are different ways you can take drugs? I'm not going to ask you to memorize all of these. We're going to kind of blast through them pretty quickly because I think most folks have taken drugs through a variety of routes, right? And that's just because we live in a society where medicines are administered. You know, how many of you people have taken oral medications? That's pretty standard. Most of you have taken medications, intramuscular injections, right? Some people have had subcutaneous, sublingual. Anybody have asthma? You've done inhalation, right? And these are all pretty standard, you know, drug approaches. If you're nauseous, maybe you've taken something, you know, intrarectal. Just kind of depends on what's going on. So, what are ways we can do stuff? You can, you know, get stuff into the GI tract, right? That's pretty interesting. Kind of two broad categories, right? Getting stuff in your GI tract and then putting stuff like, you know, through other methods. I won't think too much about that. Oral administration, that's mostly how we think of taking a lot of medications, right? People take, I don't know, I'm trying to think of standard things you take through oral administration. Birth control, right? You can take that through, you know, there's oral birth control. You also have some other methods of that that are still hormonal, I should say. You know, pain medications, cold medications, right? Anybody taking some Dayquil or NyQuil or something, that's oral administration typically. It's pretty safe, right? It's pretty easy to do. Most folks can kind of handle this on their own. You can do self-administered, and it's economical, right? It's fairly cheap. You don't need any extra apparatus to take a pill or, you know, pour a little solution in a cup and swallow it, right? The only sort of bad thing here is, where does everything go that you swallow?
Stomach.
Yeah, it goes right in the stomach, and the stomach's full of like hydrochloric acid, right? And have you ever like stuck your arm in hydrochloric acid? I can tell no, because I can see your arm, right? So that's how I know you've not done that. So hydrochloric acid is a corrosive substance, and it can definitely destroy drugs and substances that go in. That's what it's supposed to do, right? That's why your food goes in there and you tear that up. So you need to make sure that whatever drug you're taking can actually survive that environment. Insulin, for example, does not do that, right? I'm going to take a wild guess and say we all know someone who's diabetic, right? That's not a real stretch, given the number of folks who are diabetic. And they have syringes, right? And you think, why would someone want to take an insulin shot all the time? That doesn't seem very fun. Well, they have to, because there's not another way that you can really take insulin that's effective, right? So if you thought, well, I can just take an insulin pill, that makes more sense, right? Take an insulin pill all you want, but you're not going to get any benefits from the insulin because it's going to be destroyed. All right. Other ways that you can, I thought I had other, oh, there we go. Okay. We can skip these two slides. Rectal administration, this is, you know, like suppositories, not a big deal. They're great for infants, because I don't know if you ever tried to get an infant to swallow a pill. Doesn't work very well, right? If you're vomiting, if you're unconscious, you can't take medication orally for some reason, right? You know, rectal administration works. Still getting into a mucous membrane, it's going to be absorbed through the tissue in the intestines, right? So not a big deal. We also have IV injections, right? That obviously goes straight into the blood supply, right, intravenous. That's a pretty quick way to get a drug to its site, right, because we're bypassing a lot of these other approaches. If we take something orally, we go into the stomach, we've got to go down into the intestines. This takes a while, right? This can take a few hours, and then it gets sucked out into the liver and into the blood supply, and it can be delivered, you know, wherever it needs to go. If we're bypassing that whole process by, you know, an IV injection, for example, we can get to the blood much faster, right? This is why folks will, you've ever heard anybody taking a heroin pill? Nobody takes a heroin pill, right? Why would you take a heroin pill? You know, it's not going to get the drug to you fast enough, right? So you do an injection, right, if you really want to get something to you quickly. Another fairly quick way to get drugs is inhalation, right? Because you're going to get into the lungs. The lungs are full of these fun little capillaries that are for like absorption of oxygen and dumping out CO2. So if you get drugs in there, they can kind of move through there fast. I want to be clear that snorting is not inhalation. Okay, that's a different thing. Also fairly fast, right? Because you're going through the mucous membrane in the nasal cavity, right? How many of you have ever snorted drugs? Okay, there we go. Flonase, we'll say Flonase, right? That's exactly what it was, Caleb, right? So that's perfectly a normal route of administration for some drugs, right? You can see the nasal sprays, right? So that's different than putting things in your lungs than breathing that. Similar to sort of nasal administration is like sublingual, right? So you put things under your tongue, right? And then you can absorb it through that mucous membrane. Rectal administration is really the same. It's just at the other end, right? You're still bypassing, some of those digestive structures, and you're just getting right into a mucous membrane and getting that absorbed. Intramuscular, so this is kind of a nice little chart to know the difference between subcutaneous, intramuscular, and intravenous. We got to go in the vein, in the muscle, or just below the skin. That's the difference, right? Some drugs you need to put in different places. Lots of times when you get an intramuscular injection, it burns, right? You guys ever had a shot right in the shoulder, right? You get your flu shot there. I recently got the hepatitis A vaccine because I don't want hepatitis A. So I'm going to try to avoid that one. I had the rabies vaccine once. That was a fun one. I thought I was going to do work with ferrets. Yeah, that makes sense, right? I didn't end up doing work with ferrets, but I had to get 3 shots anyway.
Do they still give them to you in the stomach?
I got it in the shoulder.
Really?
Yeah, I think because it was like ahead of time. I think if it was like, oh man, a bat had attacked me, they might have jabbed me in the gut.
A bat got in my house.
And you got
And when we were
stabbed in the
little, and
gut.
we all had to get shots in the abdomen.
Yep. Yeah, no, that's a different story.
Yeah, that was fun.
This was like ahead of time. I was thinking I might get rabies, so let me try to prevent that. So I got the shots in the arms. And they burned. They typically will burn if you get a shot because the pH of the substance is different than the pH inside your body, right? So it creates a burning sensation. Just a heads up there. You guys get all your vaccines? They make you get vaccines? I
You
thought
go to
they
public
did.
school.
Huh?
You go to public school.
Yeah.
My mom would beat my ass if I didn't.
Right. Man, my daughter's mom is an anti-vaxxer, and I can't fucking stand it.
Well,
You
all
like
right.
secretly vaccinate her?
I'm going to give Caleb a +1 for that.
He gets plus a lot more than 1. Make that a 7.
Make that a 7.
Make it 7.
I am not with her though, so she's. I'll get into it another day.
Okay. That's acceptable. That's a Fat Patty's conversation
Yeah.
for later. I'm glad you're excited about getting people vaccinated because I think that's brilliant. But yeah, we should talk about that some other time.
I didn't think we'd have a Fat Patty's on the first day.
I know, right? I wasn't ready for that.
This is going to be a good semester.
Leave it to Caleb. I thought it was going to be you, to be honest. I'd already prepared to tell you to just shut it down. But no,
You never know. It could still happen.
anti-vaxxers. It's just, so,
Everyone's just irritated. Yeah, they're all just done.
but then I'm afraid there's someone sitting here like, I really am an anti-vaxxer, now I'm not going to say anything. You should fix that. I mean, not the part about you not saying anything, but the part about being an anti-vaxxer, right? It's just not based on science. It's not based on data. It's not based on evidence. It's one of these emotional decisions that people make all the time based on something ridiculous, right? So there you go.
And like Andrew Wakefield's, all of his stuff that he did, it was completely like debunked, so don't.
Yeah, there were like 8
Yeah.
kids, 7 of them didn't even have autism.
It wasn't a
and-
random sample size.
Yeah, the other one already had autism before he got vaccines.
Oh, yeah.
I was like,
Yeah.
what are you going to do with that?
The Lancet pulled the paper, didn't they?
Yeah,
Yeah.
they did. And then there's like, also like 30 years of papers saying the exact opposite. And there's like that one that was like, well, whatever.
And there's that, CDC thing.
Yeah.
And the
But
WHO thing. And
Yeah. I always, though, when I want to know about vaccines, Jenny McCarthy, always right at the top. That's who you trust.
absolutely.
Her and
She's
Jim
a guest
Carrey.
lecturer.
Right, right.
They guest lectured in my molecular biology
I'm gonna give
class.
them an honorary degree. IV, we talked about that. If you guys don't know who Jenny McCarthy is, I'm going to give you bonus points.
Just means they're younger than us.
That's fine. They dodged an idiot. And however you do it, however you dodge an idiot, keep it up. What's the problems with IV injections, right? So one, you can get like drugs to your brain almost instantly. So that's pretty awesome. The downside of this is lots of side effects, like a lot of I don't want to say side effects, like ancillary issues, right? Infectious diseases for folks who are abusing drugs, right? They're not necessarily like getting a new needle every time. They're just sharing needles and they're passing diseases around. That can happen. Some folks, John, might know about needle exchange programs, right? Those are pretty cool. Not entirely sure how effective they are. They're obviously more effective than nothing, right? So maybe we should support those. I know, then there's going to be that one person who's like, why should we give drug addicts needles? Well,
Public health.
maybe so everybody doesn't get HIV. That would be a brilliant idea.
I like free needle exchange programs, not free needle programs.
The exchange programs are
Yeah.
better, so then you can get the used needles kind of off the streets, right? And sort of out of the way of the public. And so
As
they don't-
someone who found one in her yard,
Yeah.
I'm definitely a
It
fan of the
happens.
needle exchange.
you-
One
I
for my
understand.
dog, found a new.
Ugh.
Huntington.
Intramuscular, we talked about this. Takes a little longer. Intraperitoneal, we talked about that. It's getting stabbed in the stomach. Not commonly used with humans. Happens some. Lots of times with laboratory animals, right? Anybody ever given a rat drugs? Yeah, it's kind of fun, right? So you give the rat drugs, you see what happens. You'll often just hit them in the stomach. Subcutaneous, just going right under the skin. Inhalation, we talked about that. Topical, oh, we didn't talk about topical drugs, right? How many of you have ever used like Bengay or what's the other?
Icy hot.
Icy hot, that's it, yeah. Icy hot or these Aspercream, right? And they all have like lidocaine in them. Some of them have lidocaine now, right? So that's like a lidocaine actually comes from cocaine, but that's kind of a different story. So it's a topical drug. You rub it on, causes some pain relief, right? So that's what we
You
do.
can overdose on it. Some girl was getting, I can't remember if she was getting an arm sleeve or a leg sleeve tattoo, and she kept using lidocaine
Oh, wow.
pain, and she overdosed.
Wow.
Mm-hmm.
Yeah, I wouldn't do that.
Yeah.
Yeah.
Just fun fact of the day.
Intranasal, we talked about that. Sorry, transdermal. Okay, so we didn't really talk about transdermal delivery. This works a lot for nicotine patches, hormones, right? So there are birth control hormones you can get as the patch, right? Put that on. Also, if anybody gets motion sickness, right? I don't know if anybody's in that category. They'll give you those little things you put behind your ear, right? Those little scopolamine patches, so that you can get on your cruise ship and, you know, I don't know, whatever you do on cruise ships. Epidural. Anybody had an epidural? Yeah, that happens sometimes, right? What's the most common reason you think about having an epidural?
Pregnancy.
Yeah, you're shooting something out your uterus, right? That's the number one reason to get an epidural. So there you go. It
It's
happens.
just an elegant phrasing.
It happened to all of you.
Caught me off guard.
Well, actually, I take that back. It might not have happened to all of you.
No, I was an escape hatch baby.
I was too. I was thinking I didn't go out that way, so you know maybe all of you didn't either. Some of you did, I assume. I'm assuming not all of you were C-section babies. You know, but some people are, right? You can't tell the difference really. Maybe you can.
If you look at their like microbiota, I think that's supposed to be affected.
It is, and then I was wondering if like head size, like even as adults, is different. Because like, what's the number one reason you're not coming out through the uterus? You don't fit, right? You don't fit like head and shoulders. So I'm wondering if people who had C-sections, like, I mean, at least as babies, they would probably have.
I mean, is that
I
the
do
number
look
one
weird in
reason?
hats, and they are kind of tight.
Yeah,
But like I feel
just
like,
wondering.
because like
But microbiota is definitely.
well, my sister
God.
had 2 kids and like they were like they told her that she needed to have a C-section, like not for
Really?
that, yeah, like they,
There are other reasons.
yeah.
Yeah, there are other reasons.
I need to call mom.
Yeah, just ask her, right?
Yeah.
Mom does that. You can also get injections into your brain. Boy, those are fun. You know things are bad when they say, hey, we got to crack your head open and give you this drug. So, right, that's, Kaylin, that's when you know, I did something right this time. And so we can do that intracranial or intracerebroventricular, and that sounds really fancy. There's a fluid-filled space in your brain called the ventricles, and I'm just going to go right in there and squirt some drug in. It's going to be exciting. And they're also infusion pumps, right? You get these pumps under your skin, and those continually pump, in particular, antibiotics into those ventricles. Gene therapy. We're not going to talk a lot about gene therapy in this class. I know, but I got to cut things, right? So gene therapy is one of them.
Oh, it's just that you cut epigenetics and physio that made me sad.
I know.
You're breaking my heart.
Well, I would love to teach a class like just focused on genetics, like behavioral genetics. I don't know if they offer anything on the biology department like that.
They have neuroscience and genetics, but nothing.
Yeah, I mean, most of the time, if you get a behavioral genetics course, it's offered out of the psychology department. I think that'd be pretty fascinating. Routes of administration, definitely want to think about absorption. We want to think about like peak levels, right? Because you're constantly breaking stuff down too, right? So as you're taking drugs, you've got enzymes, and those enzymes are destroying that drug you're taking. And so you're kind of in this battle all the time, right? Until you can get enough of the drug in your body to be effective. This is one of the reasons, this is why antidepressants are so awesome, right? You come in, you tell somebody, man, I'm feeling horrible. And they're like, okay, we'll take this drug. And, if you don't have a complete breakdown in the next 4 weeks before the drug starts working, come back and see me. Because they often will take several weeks before you've built up enough of the drug to where you have that nice steady state. So it's effective because you take the drug, it's got a half-life, and it breaks down, you got to take the drug again, right? You're constantly kind of riding these waves up and down until you can get it right at that level that you need. And unfortunately, the dose they give you the first go-around might not be the right dose for you. It might give you too little, might give you too much, right? You might have a really great liver or a really crappy liver. We don't know, right? Because they're, right, Caleb, most of the time they're not going to go, hey, man, let's do like, a gene panel on you before we start giving you drugs. Which would be really nice if they did that.
It would be great.
Because then they would know, like, hey, you're a fast metabolizer, you're a slow metabolizer. You know what? There's something screwed up with your serotonin receptors and that serotonin transporter, so SSRIs are not going to do you any good anyway. It'd really be helpful. So I would recommend everybody getting, now don't go to like 23andMe and go like, oh, yeah, that's good, right? Like actually get a medical professional to try to figure out what's going on. If they can do a gene panel for you, that'd be really great. Especially if you're dealing with some long-term problems and you're having some difficulty, like getting the medication, at the right levels where you want it. Good luck getting that done here.
You could tell them about the free clinic to use in the meantime.
What free clinic?
The clinic.
Oh, yeah, I should tell you.
Mm-hmm.
So we do upstairs, I always like to advertise for the clinic, the psychology clinic. If you guys, anybody know about that? Right, Marissa, you have to know. She's a TA in a work study in the psych department, so it's kind of, if you guys have been around the psych department, we do have free psychological services up on the 4th floor. It's free to students. That's amazing, right? If those folks can't handle whatever's going on for you, they'll find somebody who can, right? And they'll help you out. So they do a lot of great stuff. How many of you have ever been anxious because you're like, man, I don't know what I'm doing with my life? Yeah, just go on right up there. Make an appointment. That's what they'll do. But then they'll go, hey, let's sit down and let's chat about this. A lot of the folks that get up there are folks who are like major exploration. So, a lot of folks are like, career counseling, things like that, try to figure out what's going on. But if you're dealing with other issues, they'll help you out too. Mental health providers are expensive. They're not cheap. A lot of times your insurance won't cover those, right? But if you're a student, we do have that free service for you, which is pretty awesome, I think. They don't handle crisis kind of situations, right? But they'll get you to who will.
They do now.
Oh,
They started last semester. They have, if you live on campus, they have a counselor in
Tom,
residence.
yeah.
So
That's something.
that's
So if
helpful.
anybody live on campus? Okay. So in one of the buildings on campus,
It's in East.
it's in East. You guys know where that's located? Okay. There's this guy. Is it Tom still?
Yeah.
So there's Tom. He's one of our students in the doctoral program. He's the counselor in residence. So he's over there. He's got office hours. You guys can just walk in and chat with him.
And there's some, I know, he has office hours, and I think there's a hotline where, if you are in, a crisis, you can get a hold of somebody to transfer him to you.
Oh, okay.
So.
I didn't realize that. I knew they typically didn't handle. Now there is the counseling center that does crisis,
Yeah,
right? That's
yeah,
another
yeah.
building. They'll take you over there if you need it.
Yeah.
So no worries, it's up there. It's one of the few times you're ever going to get, I mean, what is it, like $100, $125 an hour to go talk to somebody about your
Something
problems?
like that,
Yeah.
at least.
Think about all that free money sitting up there, right? You just go up there and you talk to somebody and then you just write like down on a piece of paper, I just saved $125. You just like stick that in your pocket, it'll make you feel good.
Do they have limits on sessions up there? Because I know a lot of insurances will pay for like 10 sessions.
I don't think so.
I think, I don't.
I mean, because it's free,
Yeah.
right?
So that's a really awesome.
It's pretty awesome. It is pretty awesome. Hey, here's a great looking chart. Who loves great looking charts? Okay, a few people. Great, Seth, for the enthusiasm there. I appreciate that. Like the least amount of like effort you could put into it. Yeah, that's good. This is basically charting time in hours and basically what's the concentration of the drug in your blood with different sort of routes of administration. Here's your threshold for effectiveness, so anything below here, you're not feeling that, right? So when you take that drug orally, you don't feel it for a while, right? And then eventually you do, and then it drops off, right? Because I'm drawing purple on purple there. And you don't feel it. If you look at IV, for example, look how instantly you get that massive, because you're squirting it right into your blood, right? Right into your blood vessels. So obviously you're going to have a massive spike in the concentration of your blood. You're going to feel that immediately, and it's going to drop off quickly.
What's intramuscular in oil?
Yeah, sometimes when you get an injection, they'll put like vegetable oil with it.
Oh, interesting.
Yeah, and it changes obviously the dynamics
Right.
of the absorption.
Okay.
Kind of depends on what you want to do, right? So what's the, does it need to kind of have a slower sort of action? Notice the peak is not, and these are all adjusted for dose, right? So it's like roughly
Right.
the same dose. So, if you need a longer action and the peak doesn't matter so much, you can use the oil. Without it, you have that pretty fast peak and then a quick drop off. So it really just depends on what.
What the drug
Yeah,
needs
what
to do.
do you need to do? Why are you doing it? And
Okay.
then go from there.
I've never seen that before.
Here you go, folks. Here's like a chart. Take a look at that nice table. As I said, we do want to focus on psychoactive drugs. So I have in my life a few things I call keys to transcendental enlightenment. And the number one key to transcendental enlightenment is understanding lipid solubility. Once you understand lipid solubility, the rest of your life is easy, right? And I promise you, Alexis, write that down. You should get this tattooed, like, on your collarbone. Keys to transcendental enlightenment, and then coming around the back, lipid solubility. It's going to be a good one. So why lipid solubility? First of all, like 825% of you is lipid, right? I mean, that's not a real number. All of your cell membranes are mostly phospholipids, right? So that's that beautiful phospholipid bilayer. You guys familiar with that? You get the circle up here, the sphere, and you get the two little squiggly lines. On the other side, you get a sphere, and you get two little squiggly lines. And then you just kind of repeat this process however many times you need to in all kinds of directions, right? You created this great phospholipid bilayer. And that keeps stuff separated. It's hard to get through there. It's hard to get through these lipids.
Bless you.
Thank you. Particularly if you're trying to slide through there and you've got some sort of charge on you, right? You're positively or negatively charged. If you're rather large, it's hard to fit through there because these guys are packed in tight, right? Yeah, they're packed in there nice and tight. Now, there are some things that are what we call lipid soluble. What that means is whatever it is can slide through between those phospholipids like they're not even there. Okay? One of the number one psychoactive substances that I'm going to assume a high percentage of you have ingested that is very lipid soluble is alcohol, right? Alcohol is very lipid soluble. That's how it works. Slides right through your lipids, gets into your cells, causes things to happen, okay? We'll talk about those details later. Group 1, 2, or 5 will. I don't know which one it is. Somebody will talk about that later and we can talk about details. But lipid solubility. If a drug that you take is not lipid soluble, guess what?
You need a receptor.
Nothing's
And you
gonna,
need a transporter.
You would, right? nothing's probably going to happen.
Oh.
I mean, if you don't have that receptor, if you don't have
Right.
if you don't have a way for it to get through the phospholipid bilayer, or it's just not going to happen. You may not even be able to absorb it, right? Okay, so it may not even happen. But things that are lipid soluble, they can get in, they can do all kinds of things. Most things that are lipid soluble are things like alcohol. Small gases are typically lipid soluble. Nitric oxide, for example, is one of the big signals in the brain, right? It's very lipid soluble, just slides right through. Things that are charged, big and charged, are typically not lipid soluble, so they can't get through. When you take a drug, drugs that are effective are typically drugs that are lipid soluble. Not only does that drug need to be lipid soluble to maybe get inside brain cells and do things, before we even get there, because we might just be interacting with what's on the surface of a brain cell, right? Before we even get there, we actually have to get through something called the blood-brain barrier. Okay, this is a barrier between the blood and your brain. I know the name really was going to throw you off there, right? And you're just like, I have no idea what the blood-brain barrier does, but it creates a barrier between the blood and the brain. When you take a substance, if that's a toxic substance, guess where the first place is you want it to go? Well, not to your brain. First place you want it to go is back out your mouth and into the toilet, right? So that's what happens. Now, there are some places in your brain, speaking of vomiting, where the blood-brain barrier is weak or absent. One of those is the area postrema, which is kind of in the back. So when you take a toxic substance and it gets into your blood supply and it kind of snakes its way back there and it gets into that area postrema, it triggers a reaction or a reflex for you to projectile vomit, right? Because you want to get whatever that is you've ingested that is toxic and dangerous, you want to get that out of your body, right? So you've recognized that it's in there, recognized it pretty quickly. Some of it's probably still in your gut, so let's get that out and see what we can do. Normally, though, you don't want that blood-brain barrier to be weak, because if you take a toxic substance, you don't want it getting into your brain and causing problems, right? However, if you take an SSRI, guess what you want it to do? You want it to get into your brain and do things. That's why you're taking it, right? Okay, so it needs to be somewhat lipid soluble to bypass that blood-brain barrier. Once we get into the blood, past the blood-brain barrier, we're into the brain, then we can interact with the receptors on the brain cells themselves, on those neurons. If there are transporters, we can do that. If it's something that's really small and lipid soluble, then we might even get inside, try to get inside the cell itself and start screwing around with the DNA and the protein production and so forth. And there are a few things that you might take or think about that would do that. All right, so I don't know if you think this is a better picture than what I drew, but this is what I was trying to draw, right? So there is your sort of phospholipid, right? You've got this uncharged, what we call hydrophobic region, right, which means it hates water. And then up here you have a negatively charged hydrophilic, which means it loves water, right? And so that's why they will orient like this. So they'll put the water-hating sections together and then the water-loving sections here and here. Guess what's inside and outside of your cells? Yeah, it's mostly water. You know, ugly bags of mostly water. So there you go. That's a great insult. So that's what's going to create the spread between the inside and the outside of your body. If a drug is really lipid soluble, it can just slide right in and out of there and do whatever it needs to. But even if it's not, once it's past the blood-brain barrier, then we can start latching onto receptors, right, that are on the surface of the cell. So this is the outside of the cell. There are going to be receptor proteins out here. We'll talk about those later, so don't worry too much about that. You guys know about diffusion? You've got a high concentration, stuff's going to try to go to a lower concentration. Not a big deal. There are barriers to that, right? So for example, there's a high concentration of students in this classroom, right? And most of you want to get out, right? So because you want to spread out, right? Not because you hate the class, but because you want to spread out. That's what you naturally do. But there's a barrier to that, and that barrier is about 20 minutes, right? Because that would be the end of class, and then you guys can leave. I mean, you can leave whenever you want. You're always welcome to do that. Again, we talked about lipid solubility, gets into the brain. Here's a great example. Heroin, good bit more lipid soluble than morphine, right? That's why heroin has a much more powerful effect than morphine. That's why heroin is more addictive, right? Because it's going to have that effect more quickly. When we think about drug addiction, we'll talk about this some. Anytime you can couple the administration of the substance, the closer you can couple that with the effect of the substance, the more powerful that addiction potential is, right? Because you're going to have that sort of immediate thing. If somebody were to take heroin and, like 45 minutes later, you get your high, well, I mean, geez, I mean, you squirted up your heroin and you're thinking, well, what am I going to do now? I got 45 minutes, so you're going to go get a haircut, you can go to the library, I don't know, cut your grass, you're going to do all kinds of things. And then all of a sudden you're like, whoa, and there's, you're going to be doing some random activity and you're never going to get that sort of like classical conditioning sort of connection, right? So there you go. It's kind of interesting, right? Nobody ever thinks about those things. Weak acids, weak bases. Don't worry too much about this, because I think that's going to be. Some of you again are going to get really excited about pKa, and some of you are going to go, I have no idea what that is. And both of you can still do well in this class, so it'll be fine. pH, like I said, we're not going to worry too much about that. What you do need to know about pH, again, from like stomach acid and so forth, can break down drugs, and it can cause changes in absorption. Other factors for absorption, your stomach, empties at a different rate. Size and sex can make a big difference, right? Larger person has more body fluid, right, to dilute a drug. I always like when I read those, I'm reading my medications, obviously I'm taking some cold medications. It says for ages 12 and up, right? Ages 12 and up take this size, this dose. And I'm thinking like my nephew's 11, right? And so I'm thinking, okay, so, maybe let's say he's 12 in a year or whatever. Well, he'll be 12 in September, it's not even a full year. And I'm thinking, man, that kid weighs like 75 pounds, It's like, how many times bigger than I am than a 12-year-old, right? Shouldn't I be taking a bigger dose, right? I mean, I start thinking about those things. I'm thinking like, 2 of these if I'm 12, I can take like 6, I don't know if it works exactly like that, but.
I don't know, sometimes I've been sick enough, I've been tempted.
You've thought about it, right? Because I think, I see 12-year-olds and they're little, right? 12-year-olds are little, so why would the same dose for a 75-pound 12-year-old work for, someone who's not? I don't know.
So in clinical drug development, is that just not taken into account? Like the FDA just has a standard that above 12 and 12?
Wow, I mean, you could get hired by the FDA. Because you probably already know more than they do. Although Orrin Hatch will hunt you down. That was a really high-level joke. And if you thought it was funny, more power to you. So the FDA is, well, the FDA is the FDA, right? I mean, I don't know, how much bad do I want to say about the FDA? Or is the FDA even doing anything?
Oh, is that really
They're shut down,
Yeah,
so
so
you can talk all the bad you want, because they're not doing anything.
They're not working, those lazy bums. You know what's even worse than not working? Being forced to work and not get paid, right? So I'm going to tell you that's going to be bad. I'll tell you right now, if this place ever goes like, we're not paying you anymore, we're not having class. And the only way they're getting me in here is like Hannibal Lecter style. They're going to have to like cart me in strapped to a like a gurney, because I'm not doing it. I'm sitting at home. I got Netflix. I got other things I'll do with my life. I'm not getting paid to be here. But that's a separate story. The FDA, I mean, geez, the FDA, what do they even do, right? So yeah, they check stuff, right? But it's kind of like, well, I don't know. They do these studies, things work, things don't work. How many times has the FDA pulled a drug that's been on the market for a while? I mean, it happens all the time, right? So they're not obviously perfect. And secondly, there's a whole category of things that you stick in your body on a daily basis, I'm quite certain, that the FDA doesn't even have the jurisdiction to take a look at. And that's where Orrin Hatch comes into effect. Orrin Hatch is a senator, for those of you that don't know, he's a senator from Utah. And Utah is a high concentration of 2 things, right? One of those has no relation to this class, and the other is dietary supplements, right? One of the major sources of revenue for the state of Utah is dietary supplements. So Orrin Hatch, who's been in Congress for decades, has fought for an extended period of time to remove dietary supplements from the jurisdiction of the Food and Drug Administration, right? It doesn't really seem to make a lot of sense. If it's a dietary supplement, it seems like something you ought to be eating. Shouldn't that come under food, right? I mean, it doesn't make sense to me. So this is why you can go into your local GNC and buy a bottle of who knows what, and there's not a, it'll just say this is, like super muscle builder, and they don't even have to tell you what's in it. And you take it. It could be full of sawdust. And as long as it doesn't make enough people sick and die, the FDA will never do anything about it. They don't actually proactively check things that are listed as dietary supplements, right? They don't. So, I don't know, does anybody ever take any sort of like vitamins, right? Yeah, what's the FDA doing with those?
Nothing. Who knows what I'm taking?
Who knows what you're taking?
Who knows?
I actually saw a recent study. Anybody take protein powders? You take like mixed protein shakes? Some people do from time to time. I saw a recent study that actually organic protein powders had higher levels of arsenic in them. They had, like, yeah.
And isn't
like
organic
raisins.
itself like a controversial term because there's no actual definition for it from the FDA?
That's a whole separate story too.
Okay.
Yeah.
Is that Fat Patties?
That's probably a Fat Patties conversation. We can though talk about what the FDA does and does not do.
So like there just aren't, like that's just the standard, like above 12 and under 12 because of some physiologic change? That makes like 13-year-olds the same as 70-year-olds?
Yes. I mean, that's yeah.
At 12, your body's just like, and I'm done.
Yeah, I know, right? I mean, this is,
This is it, I'm 70.
yeah. And that's the other thing, right? Like, yeah. So I think about, like, think about your grandparents. You shouldn't be taking the same dose they take. They should be taking far less than you do, especially if they eat grapefruits. That's a problem. So yeah, I mean, the FDA, I mean, I don't want to say they're useless, but they're not as useful as they could be, or should be, right?
They politicize themselves too often.
Well, that's a Fat Patties conversation. But as much as I might agree with you on that, yeah, you're right. I mean, there's actually a great documentary out there, Bigger, Stronger, Faster, I think's the name of it. I don't know if you guys, Chris Bell. It's a great documentary. The guy actually goes to Home Depot and hires a bunch of guys who are normally like migrant workers who do roofing and other carpentry kind of things. He hires them to come to his house and make like weightlifting dietary supplements. And he's just like, I don't know, scooping white powder in these little plastic pills. And then he puts them in a bottle and prints a label on it because you can, because it's a dietary supplement. And he's like, it's like, well, it contains whatever, and it contains trace amounts of whatever. And then he's like, we'll just go sell them at some big convention, right? And the FDA goes, yeah, that's fine. If you kill a bunch of people, we'll come tell you to pull it off the shelves. But until then, have fun, make some money. And that's really what they do. I know that's a real cynical outlook on the FDA, but I'll give you the honest truth.
Meanwhile, the real drugs that actually have real medical benefit are stuck in FDA red tape.
Yeah, that happens. That's why everybody goes to Canada.
Yeah. Speaking of political.
I just meant because their drug approval process is different.
Oh, is that what it is?
That's what I meant.
Okay.
Yeah.
Gotcha.
They have a little different system up there.
A little different.
Yeah. We can talk a little bit about drug redistribution, if you wanted, but that's not too big of a deal. Cerebrospinal fluid, this is stuff that's, in your brain and those ventricles we were talking about. Some stuff can float out of that, some stuff can't. I don't think that's going to be too important for you. I want to make sure we get far enough on this. This is your, like a capillary, right? So we can talk about that. In the brain, it's a little different than it is in other places. So this is kind of like a regular capillary. There are holes, right? So nutrients can float out and stuff can float back in. It gets transported. That's what it does, right? I mean, capillaries deliver nutrients out to your tissues. That's their job. Brain capillaries look like this. Look at how we've sealed up those holes. We've got these guys coming down. These are called astrocytes. They're a specific kind of cell that's in your brain that doesn't do like calculations really. It just does support for those neurons that do calculations. But what it will do, it's got these transporters, and it will pull nutrients and other things out of the blood and then supply that to those neurons as they need it. If something is lipid soluble, then it'll just kind of slide right out of there, right? So alcohol, for example, lipid soluble, shoots right out of that capillary in your brain. And what it does is it really makes you think you have some amazing athletic abilities, when in fact you don't. You didn't in the first place, and you have even less skill, you know, when you've ingested some alcohol. It's like one of these inverse relationship things. So those guys are astrocytes. We talked about tight junctions, not a big deal. Hey, look at that. We already talked about the area postrema, or the chemical trigger zone, right? That seems exciting. That's what will make you vomit. So, happens all the time. You guys see little babies, they vomit. Yeah. Happens. Let's see. Definitely important to know if things can cross the blood-brain barrier. If it can cross the blood-brain barrier, it can do stuff to your brain. If it can't cross the blood-brain barrier, it can't do stuff to your brain. It's that simple. That's the end of the story right there. If it gets into your brain, then, you know, it can do whatever. If it doesn't, well, then it can't. And it can be just small changes. Hey, here's another sort of barrier that's important we'll talk about later, is the placenta. How many of you guys know about one of those things? Right? That creates sort of a barrier too, but there are drugs, of course, that can cross the placental barrier, and that's going to be important because we want to think about you know, toxicity and teratogenic effects. Teratogen is just something that causes a birth defect, right? And so there are a number of drugs. Valproic acid is sort of a big one that's been in the news lately, right? That's for some folks a necessary medication, and if you take that while you're pregnant, it has been clearly demonstrated to cause some birth defects. That doesn't mean, like, you know, you should just stop taking your medication if you become pregnant. That's probably not a bright idea. What I typically recommend is you put about 5 to 8 years into thinking about having kids. But don't start that until you're almost like, because you got to wait until you finish school, you get a job, you get a house. You're going to be like 28, 29, and then put in those 5 to 8 years to thinking about having a kid. And that's going to put you around 35, 36, and at that point, you know, you're probably too old to have a kid. The risk factors are too high, so you just skip right over it. So that's my word of wisdom to you. You lose out on the tax breaks, and you're definitely going into a nursing home, because your kids aren't going to take care of you because you don't have them. But
You don't have kids.
I mean, you don't have kids.
Yeah.
That's the real bonus.
that's
the real plus right there.
Yeah.
Is not having kids.
And then sometimes if you think about, like, each of you, and you think, like, are you going to take care of your parents if you're going to put them in a nursing home? I know it.
One of two.
One's going in and the other one's not. Yeah. One's going in a nursing home, the other one's going off a bridge. Well, I have a great relationship with my parents on this. My mother said, if I'm at myself, put me somewhere nice. If I'm not, save the money. So, so she's very aware I'm not taking care of her. So it's just fine. One thing to think about, and unfortunately this is a major issue here, is when babies are born and they're addicted to drugs, right? Their mothers had been using drugs while they were pregnant. Their mothers may have even been trying to stop using drugs, right? And so that's the thing, you know, if you're a heroin addict, what are we going to do? Methadone, right? There are other approaches, but let's just say methadone for now. We're giving you methadone to kind of get you off the heroin. The problem is, guess what? Methadone's an opiate as well, right? I mean, Brandon, we're still giving you the drug, right? I mean, it's a different strength, but we're putting it in a fetus. So it comes out the same, right? I mean, so it's really, it's a tough situation. I mean, it really is. So how do you handle that? And we don't even really know a lot of these effects, right? It's really hard for us to track the long-term effects of these opiates on kids who are born addicted to them, partly because if you start to think about sort of the family life and structure of those individuals, they're often not likely to sign up for these longitudinal studies, right? They're not bringing their kids back every week to get them tested, right? I mean, they don't have that kind of support structure in their lives, and they're not always willing to come back in and do these things, especially if they're still continuing to use drugs. You know, if you're a drug addict, the last thing you're going to do is come back into some official building, right, and go like, yeah, I'm still using drugs, and here's my kid that I also had addicted to drugs. Let's see if there's anything wrong with it. You know, they're not. It's kind of a difficult situation. It really is. And unfortunately, in this area, I'm not telling you guys anything you don't know. We have an extremely high rate of infants who are born exposed and addicted to serious drugs. There you go. That wasn't really uplifting. I got 5 minutes to
Yeah,
get you
you
guys.
gotta bring us back
I got
up.
5 minutes to get you back up before you
Gotta
go.
lift us back up on something.
Well, cocaine, that'll get you going.
I
don't
But no,
know.
that's not the drug we're supposed to do. We're supposed to do LSD.
You're supposed to do LSD, which will make you feel better.
Okay.
Teratogens, there are all kinds of teratogens, X-rays, drugs, get infections, not a big deal. It does matter, like what's the trimester when you're exposed. It makes some difference, right? What's getting developed at that time. There's always this debate about like, is it okay to drink alcohol while you're pregnant, and if so, when? Right, and there's sometimes people will say like absolutely not, and there are people who say like, well, you can if it's like at this time. Don't. That's just easier, right? Because you don't know, we don't know, we have no idea. Sample size isn't. It's hard, right? Because it's. So let's go round up, 50 women. Let's get them all pregnant. Let's give half of them alcohol, and let's not give the other half alcohol. Let's see what happens, right? That seems like something they're going to let me do. I mean, I just.
Who needs the IRB?
Yeah, I mean, it's just they're not gonna. Nobody's gonna let me do that. That just doesn't seem like a study that's getting passed through.
Made me think of baby zoo.
I
The baby zoo.
That's a whole different.
That's a fat
That's a
bastard.
Oh, God,
whole different
that's-
thing. We shouldn't even talk about it on campus.
Wow.
There are drug depots. These are places where you can stick drug molecules. They get tied up. They don't get to the active site. They don't get metabolized. But what's kind of interesting is they will get released at a later time, right? And so this can happen in muscle, fat, some of the proteins that are in your blood plasma can tie up these drug molecules, and then later they can release those when that drug concentration drops. This is one of the reasons why you got to wait 4 to 6 weeks for that SSRI to kick in, right? Because for 4 to 6 weeks, you're just sticking in your fat and muscles. You're not actually putting it in your brain. You just keep taking those pills, Keep giving me that Lamictal. Let me see what happens. And you're like, man, I don't feel any better. I don't feel any better. And then all of a sudden, you get that concentration where it needs to be, and you can start moving things around a little bit. Not a big deal. Non-selective. THC does this. This is one of the reasons that THC you can detect that in your urine for a long time, right? Use marijuana once, several days later you can still detect urine in the bloodstream. This is actually a real problem. So like I can really just take the like, hey, don't do things that are illegal kind of standpoint on things, right? Because they're illegal and you guys can get in trouble. Now that marijuana use is legal in some places and not in others, it becomes a real issue for people who live on one side of a river and work on the other side of the river, right? Let's say you live on one side and you've got a prescription for your medical marijuana, and on the other side they say like, that's the worst idea we've ever had. And so then you take a drug test and you're like, well, I'm following my doctor's orders. And so it really creates these sort of, because we don't have a nationalized sort of approach to this, it creates a real problem, especially in an area like this, where you can drive to 3 states in about 15 minutes, right? And I'm going to guess a number of you, most of you probably live in West Virginia, I'm going to say a number of you probably live in Kentucky and Ohio, right? I mean, that's a reasonable expectation, or at least go there on a regular basis, even if it's accidental, right? Like, oh man, I'm driving down 3rd Avenue, and next thing you know, you're in Chesapeake. It happens. You try to go to Bob Evans, and you miss the turn. So next thing you know, you're like, why am I on a
This
bridge?
seems kind of personal. Did this maybe happen to you?
Didn't happen to, well, I'll tell you about this one time. My wife was driving, and we ended up in Indiana once, driving up the down road on the interstate, which was kind of frightening.
Oh my God.
Yeah, that was pretty frightening. I was like, what are you doing? And there were like cars coming at us. She's like, I don't know. I was like, I don't either. But we should be going the other direction. So, yeah, it's the way it goes. All right, let's stop there with depot binding. We'll pick up here next.